disorders. The main interventions for children with autism are apply behavioral analysis-based interventions such as Lovaas model, early start Denver model. Medications are mostly used for challenging behaviors such as repetitive behavior, hyperactivity, and noncompliance. The evidence of efficacy of early intensive interventions has we probably seen quite often in the literature, and the National Research Council guidelines recommend at least 20 hours per week of the behavioral intervention from clinician initiated at an early age, and also parent training and parent delivery of at least 5 hours per week. The approximate annual costs are $50,000 per child. Now families have pushed for an understanding of which treatments work best under what circumstances in order to optimize outcomes. Economic evaluation has the potential to increase access to underprovided services that are effective in improving health. It provides information on the potential values of effective interventions and allows implementation scientists and decision makers to target interventions that are strong candidates for dissemination and implementation. I would like to spend a few minutes to cover some background of economic evaluation before getting to my project. The framework of economic evaluation is proposed by the U.S. Panel on Cost Effectiveness in Health and Medicine in 1996 using quality-adjusted life year, or QALY, as a standard metric. Since financing services for children with autism depends largely on perception of value, so economic evaluation has an important role to provide this information, and QALY measures are necessary for developing economic information. Some of you may not be familiar with QALY, so I will go over a little bit what it is and how to calculate it. In general, we can measure health outcomes using health status measures to describe health profile, such as health-related quality of life instruments. I'm sorry, I think okay. Let's go back to the previous slide. However, the descriptive health profile, like health-related quality of life, cannot directly translate into QALY for economic evaluation. So there are another type of measures which call preference-based measure that can produce a health utility index that can be used to calculate QALY. So the health utility index score ranges from 0 to 1. So 1 represents perfect health. So QALY is calculated by multiplying the health utility scores with life years left, which reflects how conditions impact mortality and morbidity in the same time. A rule of thumb for QALY gains for intervention should be at least 0.03. So we can say that the interventions clinically improve the condition. So this figure just shows the difference of health status or health outcome with and without treatment. So you can see that this health outcome reflects health condition of a patient without treatment. But if a patient receives treatment, you can see that this is the QALY gain. The difference in this graph show that this is the health gain or health improved from the treatment in terms of QALY. We are not aware of any studies that have evaluated benefits of early intervention services for children with autism using the QALY measure. So in our study, we investigate how many children receive early intervention and whether services improve health outcomes in terms of QALY gain. So our study is a retrospective observational cohort study design using data from the Autism Treatment Network from 2007 to 2013. We identify children who receive intervention based on parent-reported data collected at the first visit or at the enter point in the registry. Children who receive any interventions before or at 5 years old at the first visit were categorized as a treatment group, while children who did not receive any intervention were categorized as a control group. And we use propensity score matching in the ratio of 3 to 1 to generate a control sample of children who did not receive any intervention. When we use the PQL, Pediatric Quality of Life, or PQL total score at the first visit as the outcome, and then match age, ADOS severity, and cognitive ability or IQ between the treatment and the control group. We use the last observation carry forward method for missing PQL total score at the 2-year visit or the third visit number, and then we converted the PQL total score into health utility score using a mapping algorithm that I will show you in the next slide. And we use a repeated measures mixed model regression to test if health utility scores, or I can call QALY gains, QALYs were different between the treatment and the control group. So we have two groups. The treatment receive any intervention at the point of baseline enter into the ATN, and at about 2-year visit. This group is the group who did not receive any intervention. So this is the model that I use to convert PQL total score into health utility score. So in addition to the total score of PQL, in the algorithm also use the ADOS severity, age, and also IQ to predict the health utility score at the baseline and also at the point of the 2-year visit. So this is the table of all the intervention reported from parents of children with autism. You can see that there are several services, including behavioral and educational intervention that reported in the registry. So about 83% of children receive some type of behavioral and or educational intervention at the first visit. And half of the children who receive any intervention reported utilizing the service at 5 years old or younger. And the average report total hours services is 9.5 hours per week. And only 10.6% receive 25 hours or more per week. And this table presents characteristics of children in the control and the treatment group. Children who received the treatment had relatively higher ADOS severity score and receive an autism diagnosis more than the control group. You can see this is the intervention, the treatment group. This is the control group. And the treatment group also have a little bit lower IQ than the control group. And when we apply the cutoff point of cognitive impairment, you can see that the treatment group, there are 46% that have IQ below 70, while it's only 36% of the control group that had IQ below 70. However, the scores on PQL, CBCL, violence, and also the sleep habit score are pretty much much similar. After the matching process, we had 190 children in the control group and 1,270 in the treatment group. And after we applied the age criteria for the treatment group, the final number in the treatment group that used in the analysis was 626. And in our regression model, the estimated treatment effect for the early intervention services suggested that children gain 0.099 QALYs. As I mentioned earlier, that the minimal clinically important difference for the QALY gain is 0.03. So this number is not marginal. It's actually considered large and has the potential to be highly cost-effective. However, the results I present today is just a preliminary analysis. We have some limitation and concern that we show here. Now the result that we see, we counted all types of behavioral and educational services reported in the data. We recognize that some services may not be relevant, so we will discuss more which services should be included in our final analysis. And also we have some sample size limitation when we try to looking at the follow-up visit. At the end, I would like to thank my research team, Mick Tilford and Richard Fry, as well as Karen Kusal. And also the most important group that helped me to getting these preliminary results are Amy Xu and Eric Macklin. Thank you very much, and I'm happy to entertain questions.
Thank you, Nalin. So does anyone have any questions? You can go ahead and type them into the search bar, or you can raise your hand if you'd like to ask over the phone.
Oh, I'm sorry. I just saw that I need to speak louder.
And Nalin, did you have any questions that you wanted to pose the audience about your project?
I'm kind of thinking about all the services that are included in the data. I'm not sure if some services which one I should exclude from the treatment group, because now I count all types of services. Like the physical therapy may not be relevant. So if anyone has any suggestions, please do so.
Okay. Well, while we're waiting for anyone to speak up about suggestions about services to be included, I do have a question for you from the audience. They would like you to talk about how the QALYs in this study relate to QALYs in other studies of children with autism or just other studies of children in general.
This one is only, do you mean the QALY that in my study? This is specifically for children with autism. And I'm not sure what is the question again?
Do the QALYs that from your study relate to any QALYs from other studies that you know of, either of children with autism or just other studies of children in general?
I have not seen any study that use actual QALY, that calculate QALY gains in children with autism, but I have no information in study in children in general. And I see the questions earlier asking if the QALY is equal to 0.1 gain at 2 years. Is that the question? So the finding that we reported here is the change after 2 years when compared between the two groups, and we all accounted the time difference into the model. So the QALY gain is 0.1 in 2 years. So actually, when we did using literature review, I look at the early start Denver model. The gain that we try to use our mapping algorithm to apply to the result presented in the literature. The early Denver model gain approximately, if I remember correctly, is 0.13. So it's higher than what I estimated here using the registry data. That's also
okay.
the 2 year, but the information I said is not published. It's just our own work that we looking at different studies that we can find in the literature that have information that we can apply our mapping algorithm.
Okay, great. Thank you for that explanation. And then we also have another question about the slide showing severity scores on the ADOS and if they increased for the group of children receiving services.
All the information in the table is at the baseline, so I don't think that we have the ADOS severity score at the follow-up visit. So all the information reported are at baseline. So we assume that it doesn't change. So because we don't have the information on that.
Okay, great. Thank you. Did anyone else have any other questions? Okay. So thank you so much, Nalin, for your presentation. We're going to go ahead now on to Rachel and her presentation.
All right, thank you.
Thank you. Thank you for this opportunity to present my work and to obtain feedback from others before things are completed. I also want to thank Beth Mallow and Zach Warren at Vanderbilt for mentoring me on this project, and Amy Hsu and Eric Macklin at the DCC. Today I'll be talking about my work on repetitive behaviors and sleep disturbance in autism spectrum disorders. The objectives include an overview of sleep problems in autism, reviewing research on the categorization of restricted and repetitive behaviors, and to discuss planned research using the AS ATN Registry data. Sleep disturbance is a frequent concern in childhood, but especially so for parents of children with autism. Approximately 50 to 80% of children with autism have sleep problems. As a comparison, about 32% of typically developing children have problem sleep, and about 46% of those with developmental delay. Most of the data on sleep problems comes from parent report on questionnaires, though some research has used physiological measures such as actigraphy. The most commonly noted problems include sleep onset insomnia and nocturnal awakenings. There are some changes over the course of development, with parents of younger children reporting more parasomnias, things like night terrors or sleepwalking, and bedtime resistance. Older children typically have more insomnia or difficulty falling asleep. The causes of sleep problems are multifactorial, potentially including medical problems such as asthma, seizure, obesity, restless leg syndrome, circadian rhythm disorders, and genetic risk. There may also be behavioral issues that contribute to problems with sleep hygiene. For children with autism, sleep problems are associated with overall severity of ASD symptoms and with behavioral problems, including aggression, self-injury, disordered eating, and adaptive deficiencies. Some research has associated sleep problems with specific features of autism, including stereotypy and social skills deficits. Thus, disrupted sleep is particularly salient for treatment, as it may worsen symptoms of autism by increasing restricted repetitive behaviors and problems in social affect and communication. The restricted and repetitive behavior category of autism classification encompasses a wide range of behavior. A growing body of research has suggested that restricted repetitive behaviors can reliably be parsed into at least two categories: repetitive sensory motor behaviors and insistence on sameness behaviors. Some groups have also found evidence for additional categories, including self-injury and circumscribed interests. Differences in the number of categories found may be related to specific sample characteristics as well as instrumentation. The majority of this research has used parent report data from the RBSR, which is Bodfish's Repetitive Behavior Scale, or from the Autism Diagnostic Interview, the ADI. Repetitive sensory motor behaviors are characterized by repetitive use of objects, complex motor mannerisms, and sensory-seeking behaviors. Higher rates of repetitive sensory motor behaviors have been associated with younger age and lower IQ. In contrast, insistence on sameness behaviors are defined by rituals, compulsions, and resistance to change in routines. There have been multiple studies on the relationship between these behaviors, age and IQ. Findings have included either a positive relationship as well as lack of association. And as you might imagine, insistence on sameness behaviors do have a small overlap with anxiety. Kate Gotham had a really nice paper on this overlap in Autism Research in 2012. In previous research, these behavior clusters have been correlated with each other, but they also exhibit different relationships with other variables such as IQ and age, indicating that they do function as independent constructs. To our knowledge, no previous research has examined the association of separate repetitive sensory motor behaviors and insistence on sameness behaviors with sleep problems. It is likely that the intensity and type of restricted repetitive behavior is associated with being a good sleeper versus a poor sleeper. Our aim is to explore the relationship between specific types of restricted repetitive behaviors in sleep, and we'll begin by seeking to confirm the presence of these behavioral clusters within ADIR data. The AS ATN Registry represents an ideal, large, well-characterized sample in which to test hypotheses. So our hypotheses include that higher rates of repetitive sensory motor behaviors will be associated with more sleep problems, including bedtime resistance and sleep onset delay. Clinically, we've heard from families that repetitive sensory motor behaviors may interfere with sleep initiation, such as the child who's repeatedly stimming by vocalizing at night. Our second hypothesis is that insistence on sameness behaviors may be beneficial or protective for sleep by promoting adherence to a bedtime routine. Participants will include children aged 2 to 18 in the registry whose parents have completed the Autism Diagnostic Interview. Primary measures will include the ADIR and the Children's Sleep Habits Questionnaire. We also will use secondary measures, including intelligence scales, the Child Behavior Checklist, the ADOS, and the Vineland, to characterize the sample and to control for known factors associated with sleep disturbance. Currently, the first steps in the analysis plan include performing a confirmatory factor analysis to detect repetitive sensory motor and insistence on sameness factors in the data. We're following a paper by Summer Bishop, published in JAD in 2013, that identified specific ADI items which loaded on the latent factors. I'm happy to provide those items in the discussion later if people are interested. We'll use goodness of fit indices to determine how well the model fits the data. If the confirmatory factor analysis does not support the model, then follow-up exploratory factor analysis will be used to determine a structure that best fits the data. If results of factor analysis do support repetitive sensory motor and insistence on sameness factors, severity scores will be calculated by summing the ADIR items for each child in the relevant categories. We're using parent report of current behavior on the ADI because of our interest in linking that up with current sleep problems. We'll also follow ADIR coding conventions of converting 3s to 2s in scoring severity. Bedtime resistance and sleep onset delay subscales can easily be derived from the Children's Sleep Habits Questionnaire. These scales will be regressed against the repetitive sensory motor and insistence on sameness scales, controlling for previously known markers of sleep disturbance. So at this point, I've received the registry data. The ADI has been converted for analysis and compiled into one database. I've cleaned relevant items. There were approximately 1,000 cases overall and about 400 that have the specific items answered that I'll be using in the analysis. My immediate next steps will include the factor analysis and coding data to achieve the severity scales. I'll be building in remaining measures to examine the relationship with sleep. Clinical outcomes may include a better understanding of restricted repetitive behaviors in sleep, which would allow providers to tailor interventions to best fit the needs of their patients with autism. Behavioral and medical interventions could be developed based upon a child's specific restricted repetitive behavior profile. For example, a child with high rates of stereotypy at bedtime may need more assistance with sensory issues, learning to compensate quieter behaviors that could promote sleep, or more medication supports. Children who show high rates of insistence on sameness may need further attention to bedtime routines and the transition to their bed. In terms of research, future directions may involve deriving, we note that deriving repetitive sensory motor and insistence on sameness factors from the ADIR data in the registry may be helpful for a number of additional projects, including links with genetic data in the biorepository. Thank you. And now I can take questions.
Thank you, Rachel. So does anyone have any questions for Rachel? You can either raise your hand or type them into the questions box. Let's see. And Rachel, did you have any questions that you wanted to pose to our audience?
Yeah, one thing I've been thinking about is the IQ data and controlling for IQ as a known factor in predicting sleep disturbance. There was a previous paper by Joel Holloway that showed IQ positively predicted sleep disturbance, so that children with Asperger's disorder were more vulnerable than others. In the ATN registry, there are a lot of IQ measures, and there are a lot of ways to think about IQ. Maybe choosing nonverbal is the best estimate, going with a full-scale IQ, combining the different measures, and also how to think about if the Nalin was used as the developmental or IQ measure. I just wondered if any of our folks on the call had worked with this data or had ideas that were helpful.
If anyone has any ideas, you can raise your hand and I'll let you speak.
I definitely have some places to start with that, but I'm happy to take contributions to that as well.
Okay, that's great. So if anyone wants to raise their hand to answer Rachel's question, I also have a question for you, Rachel. Do you have any thoughts about how anxiety may contribute to both repetitive behavior and sleep problems?
Yeah, we know that anxiety may be a big issue, especially for children who might be a little higher functioning. I mean, clinically we hear that children often are lying in bed, worrying at night, and that may point to different types of treatment, either learning more behavioral methods to relax themselves at night, as well as medication supports. We do know there is a little bit of insistence on sameness overlap with anxiety, and so I will be looking at that in this data as well. I don't yet know how to predict how that would come out, but that's something we'll be looking at.
Great,
Rachel,
thank you.
Can you hear me?
I can.
Oh, great. This is Dan. Wonderful presentation. So along the line of your question regarding IQ, it would seem that when it comes to tailoring some treatments, you might have an opportunity for a wider variety of treatments with a patient who has a higher IQ, especially if that's mostly showing up as verbal IQ and we're better able to communicate with them, and then teach them, you know, self-calming strategies or make it clear to them the bedtime routine that we're trying to help them adopt and so forth. Do you think that, or are you thinking along that line that you would see that kind of a change? You mentioned Jill Holloway's study, which sort of went against what other work has been out there, which suggested that lower functioning people with autism had more sleep problems, and sort of suggested that there was a lot more that was affected neurologically, perhaps. So do you have any kind of thoughts of what you might do differently with them in terms of treatments?
What I might do differently with a child who had a higher IQ?
Yes.
You know, I think that is fair, that they might be able to be taught more strategies themselves. And then we might be thinking about more parent-led strategies for children who are more limited in terms of their developmental functioning. Children who do have the higher IQ might be able to use something like the bedtime pass, might be able to understand more visual scheduling about a bedtime routine, or even making their own list about how their bedtime routine would work and contribute more to that plan. And then children who are more limited, again, might need more parent support around that. Parents thinking about what are the sensory properties of the child's bedroom and trying to adjust that way.
Okay.
Does that answer your question?
I think so, yes. And I think Nalin might have a question. I don't know if we can hear Nalin or not.
Yeah, I just wondering about the kind of visit. As I understand that the IQ, the information of IQ has only available at the baseline or the first visit, and child sleep habit questionnaire is a different time visit. So I just wonder how you will control that. Because when children grow up, the IQ normally change. Is that correct?
IQ is a fairly stable construct after about age 5. We'll certainly want to characterize the sample in terms of the age and the IQ. My choice, if we have multiple assessments with a child, would be to choose the visits where the ADI and the children's sleep habits questionnaire were administered closest together. And then IQ is more of a secondary analysis for me. Right, you're right that IQ may have changed a little bit, and we'll have to just, I think, make a note of that as a possible limitation if there's a wide time frame between that. But thank you for suggesting it. That's something I know that I will need to look at.
I'm thinking about my own project, the same problem too. So I just wonder if you have, some idea how to deal with it.
I don't expect IQ to change markedly. It may be more important for your study to have IQ kind of point-to-point differences. For mine, I would be looking at a broader characteristic of generally average IQ, well below average IQ, or above average IQ.
I see. That's great. Thank you.
So do we have any other questions for Rachel in regards to her project? Don't think so, not at this time. So we're going to go ahead and move on to Maria's project. Maria?
Okay. Thank you, Audrey, and thank you to the AIR-P and the ATN for their support of the Secondary Analysis Initiative. I also want to thank my collaborators at the Lurie Center, and special thanks to Amy Shuey for all her patience at the DCC as we go through this fishing expedition of trying to find relationships in the data. So, here we go. So, as the title suggests, the focus of this presentation is on the relationships between motor deficits in autism spectrum disorder and their communication deficits. And here, communication, I'm referring specifically to speech and language deficits. And the motor component is something that both Kanner and Asperger have commented on way back in 1943, 1944, and something that we as investigators and clinicians have observed consistently in working with this population, both in kids and in adults. So then, what are some of the motor problems that we often see in this population? And that is going beyond the stereotypies, the repetitive behaviors, the restricted behaviors. Things like the head lag, which at 6 months of age in these high-risk infants is associated with ASD later at 3 years. Dystonic movements, motor control, complex motor planning, and this is something that's very characteristic, the difficulty with coordination and planning. And of course, both from postmortem studies and non-invasive neuroimaging are findings of atypicalities associated with motor impairments, things like an enlarged caudate nucleus or decreased volume of the cerebellar vermis or delayed functional specialization of the motor cortex. So then the question is, to date, when I say a lot of us have observed these, what has research shown about the relationship between the motor system and the language system? And not surprisingly, if we start with the first reference there by Kujala and colleagues, even those individuals on the spectrum who are high functioning are known to have very subtle articulation problems. So clearly that's suggestive of some kind of articulatory motor planning or motor issues potentially. People like Kate Alcock or Merton and Gernsbacher or Krishnan or Max Belmont and all of them, clearly their work too suggests that there is this relationship between non-speech oromotor planning and execution and speech and language presentation or performance. So, for example, if we think of a very well-known measure in the field, namely what is called non-word repetition today, it's clear that oromotor control has predicted with the most variance in this non-word repetition abilities. And since non-word repetition has come to become some kind or accepted as a clinical marker of language impairment, it's something that was used also with the KE family in England. So all of this evidence points to some oral motor component in the speech and language deficits we see in this population. Interestingly, even the neuroimaging studies with when subjects are not doing anything, where it's a resting state study, Steve Peterson and his colleagues at WashU, Jonathan Power, Brad Schlager, and all of them, they found a very tight coupling between the mouth regions and the auditory regions in the brain at rest, suggesting that perhaps what they refer to as functional histories, the coupling through linguistic usage of these two areas. Also work by Fadiga and his colleagues from the Italian group working with Rizzolatti, they too have shown this increased motor evoked potential during listening to speech sounds, sounds that evoke strong articulatory gestures, tongue movements. So it suggests that even at the level of speech reception, speech perception, the whole act of listening is at some level being mediated through the underlying articulatory apparatus. Our data, our efforts here is to look at this relationship between the motor skills and autism spectrum disorder, controlling for age and IQ in the ATN cohort. And a very broad hypothesis here is that the fine and gross motor skills will be associated with receptive and expressive language, simply because, as I alluded to in the earlier slides, there is a motor planning and coordination component, i.e. speech gestures, that come into play in speech and language. Oops. So what are the variables that we selected from the ATN database? We selected, there were many, many variables, and we just selected a subset here, and we were guided by our need to maximize our N, so to get better signal to noise in our results and have interpretable results at the end of the day. So for those of you who are familiar with many of these measures, you'll see I have not included here measures like the SELF, which is a clinical evaluation of language fundamentals, or the OWL, which is oral and written language skills, because the N was very small. And also, once we start doing a relationship analysis with other variables, we are bound by what's available in terms of a subject having received both measures. So the measures we focus on here today for receptive language is Mullins and the PLS. For expressive language, Mullins and PLS. For fine motor, we go with the Mullins. For gross motor, we go with the Vineland gross motor. For social behavior, and here I know this might be slightly controversial in the way I'm using it, but to the extent that social communication is now the buzz term in as per DSM-5, we are using, for lack of other measures, the VABS interpersonal relationships raw scores as a measure of social behaviors. And why we're using that as some kind of proxy for social communication is because we know that when an individual has difficulties with social communication or with motor behaviors, that being the focus of this study, they tend to withdraw from their peers because either they feel rejected or they are in some way made to feel isolated. And that can be a vicious circle to the extent that then the individual doesn't have those opportunities to develop their speech and language skills. So that's the justification for using social behavior as one of our measures for looking at communications as well. And we control for variables like meds, ADHD meds, and muscle tone, age, and gender. For IQ, we used primarily the Mullen visual reception, which is a measure that's popularly used as a proxy for nonverbal IQ, and the Stanford-Binet. Just to clarify also, the measures we use when we use different tests, we don't combine them in any way because of issues with construct, validity and the ability to match across these various measures. So what do we have in terms of availability? The N you can see in the columns over there. You can see right away what jumps out at you is the PLS is the small numbers there available for it. But it was definitely higher than what was available for SELF or the OWLs, which was closer to 50 to 60 only for the SELF, and for the OWLs it was like 150 or 160. And the scores, the min and the max in terms of raw scores, are there in the right-hand side column. And the statistical analyses that I'll be focusing on and presenting today are those from the linear regression. We have several other statistics which I will not be reporting to today in the essence of time. They look at correlations and t-tests, and hopefully we'll get an opportunity to discuss that another time. So the results so far. The first measure we looked at was with expressive language and how it relates to fine motor, and the test measure here is a Mullen for both. And we found there to be a significant association between the two when controlling for age, nonverbal IQ, ADHD meds, and muscle tone differences. And at the bottom of the slide, it's summarized as for each unit increase in fine motor score, the Mullen expressive language score increased by 0.4, and this was statistically different. So in a nutshell, a significant relationship between expressive language and fine motor abilities. As far as expressive language and gross motor measured by the Vineland, a comparison there found that these two variables also to be significantly associated, adjusting again for age, nonverbal IQ, ADHD meds, and muscle tone differences. So for each increase in gross motor score, the Mullen expressive language score increased by 0.1. So both expressive language is associated with fine motor and gross motor in these two slides that I've just presented. In this next one, we look at receptive language and fine motor. And again, we find a significant association between these two, once again adjusting for the usual variables, the age, nonverbal IQ, ADHD meds, and muscle tone differences. And here we see for every unit increase in the fine motor score, the receptive language score for Nalin also increases, and that increases by 0.3 and highly significant. Now when we look at receptive language with gross motor, however, with Vineland, interestingly, we found no significant association over here. So receptive language was not significantly related to gross motor. When we saw that, we started to ask the question as to whether in some way the fact that in the previous slide the receptive language was associated with fine but not with gross, was that association between receptive language and fine motor maybe something to do with an exaggeration due to the fact that the same measure, i.e. the Mullins, was used to measure both those measures, right? To get a measure of receptive language as well as fine motor. So we decided to use another measure of language to look at this relationship. And this time we chose the PLS, and receptive and expressive. And once again, it was a bit of a fishing expedition just because we had to maximize our N. We chose the same variables to control for age and nonverbal IQ and meds and muscle tone, and trying in various combinations. And what we found was that once again, the receptive was associated with fine motor using PLS, but not when adjusted for age. The expressive language, however, was not associated with fine motor. So once again, if we keep in mind the results from Mullin and versus the results from the PLS, one possible explanation here for the discrepancy is the huge difference in the N that comes into play when we select the PLS as our test of choice, because we only have a sample of between 300 and 350 versus the close to 1,600 and 1,700 participants for the other analyses. The other possibility is that when you go with such a small N, like 300, the age factor might come into play because we are forced to select from that subset only those that have both sets of variables of comparison available, i.e. the PLS receptive expressive and the Mullin fine motor. So we decided to dig a little deeper and said, okay, if we go with that relationship between verbal ability and motor ability, we decided to use the expressive language median score, a split, and divide this group into those with higher ability versus lower verbal ability. And this was motivated by the findings of Kate Alcock, if you remember in one of the slides I presented earlier, of what she found was a significant relationship between the speech and language ability and the degree of the motor abilities, or the severity of the motor problems. And what we found was that this higher versus lower ability, and looking at gross motor scores, we found that the higher verbal ability group has gross motor scores that's about 2.1 units more than the lower verbal ability group. So this is in some way consistent with the general theme that the higher the ability, verbal ability, the better the motor scores or motor skills. The secondary aim of this study was looking at, or these analyses, was this relationship between motor skills and social pragmatic difficulties, the social behavior measured by the Vineland interpersonal relationships. Here we see that social behavior was found to be significantly associated with gross motor and fine motor after adjusting for age and nonverbal IQ. If we look at the bottom of the slide, and we see that if we were to even use the Stanford-Binet instead of the nonverbal IQ measure of the Mullen, the results remain unchanged. Just as a point of clarification for those of you who might be questioning this, the Stanford-Binet, although there's a fairly large N available for the Binet, as I said earlier, when we are interested in looking at these relationships between motor and speech and language and motor and social pragmatics and controlling for IQ, Stanford-Binet was not always available. So to maximize our N, we went with the Mullen visual reception as our default measure for the most part for nonverbal IQ. To summarize then, these very preliminary results from the secondary analysis support a significant relationship between language deficits and motor skills in ASD. Interestingly, whereas expressive language is associated with both gross and fine motor skills, receptive language appears to be linked with fine motor abilities. Both gross and fine motor skills appear to be related to social behavior in keeping with a role for gestures. And by gestures here, I'm referring to both manual, facial, and speech, to the extent that all these modes of communication are ways of communicating. If we were to, just to take a little step outside of this, what we've been talking about, we think of the mirror neurons, we think of work by Rizzolatti and his colleagues, we think of the work of Michael Corvallis or Michael Stafford-Kennedy or Al Liverman, and we think of the area F5 in the rhesus monkey, and the fact that that area houses the mirror neurons, and that is the homologue of our human Broca's area. We can think of this as a way of connecting the dots between manual gestures to our oral motor, i.e. speech gestures. So that's the linkage, and that's what we're hoping to go after when we have more measures, either from the ATN or from other studies, to better understand especially nonverbal autism. As to next steps, additional analyses are in the pipeline. So looking for significant differences more by way of t-tests, looking for groups that are more homogeneous, so we try to subgroup, match, even if our ends shrink quite a bit, but looking for differences in impaired and unimpaired groups, impaired and unimpaired in terms of language, and then relate that to the difference in the motor abilities of these groups. I'd like to acknowledge the ATN, AIR-P, and the registry in general. If there are questions from the audience, from the attendees, I welcome those. And as you'll see, I definitely have a few questions myself. Thank you.
Thank you so much, Maria. So we do have a question. Just if you could speak to the clinical implications of your findings.
It may very well mean that we need to acknowledge that there may be a subgroup of individuals on the autism spectrum for whom the motor issue appears to be the core issue and impediment to their speech and language deficit. So if you look at the work by Matt Belmont and his colleague Pratibha Karanth with the group in India, there was a subgroup over there that appeared to not respond or respond much more slowly to the intervention. And when they looked at what divided these groups and their response to the therapy, there appeared to be the motor component in these subgroups that dictated their response to the intervention. However, having said that, I would like to add that an interesting finding, in my opinion, in that study was that there was also the high receptive language ability in that smaller motorically impaired group that would respond to motorically based intervention. So you are building on an existing base that would allow you to ensure the use of a motor system, whether it's gestures, pointing, manual modes to bring out hidden capacities.
That's great. Thank you. So we're just about out of time. We have another question, or more of a comment. Just concerned that the GM measurement you're using is actually a parent report, whereas RCLG, XPR, LG, and FM are clinical measurements. Have you considered using a different gross motor measurement that may have a smaller N, but may be more accurate assessment of gross motor skills?
I love that comment, and thank you for that. We have gone back and forth with our own criticisms and our own thoughts about, investigator-initiated as opposed to self-report. I will definitely be pursuing that suggestion. Yes, thank you.
Great, thank you. So as we kind of finish up, I would just like to just kind of offer that if anyone has additional feedback for our presenters, questions, you can always email them to me, Audrey Wolf. My email address is on the invites from the GoToWebinar site that everyone gets. And just kind of a reminder that there will be an evaluation that you can complete for CME credit. And also this webinar presentation will be available on our YouTube page, and that link will also be emailed to everyone. But if you have any additional comments for our presenters, questions, feel free to reach out and I can put you in touch with them. So thank you to Nalin, Rachel, and Maria, and thank you to everyone for attending. That's it for today.
Thanks, folks.
Thank you.
Bye now.
Thank you.